Thank you very much for the invitation to come and speak today to Peter and Evan, and also live music now in the Royal Society of Medicine. So I'm going to follow on actually quite nicely from Ray's material, because I'm actually talking about evidence. And I'm talking about evidence so that we can at least be aware of what the evidence is, to then think about how we might engage with it and how we might try to shape the evidence. I'm going to be focusing very particularly on two Cochrane reviews, a published Cochrane review on music. It was actually music therapy for acquired brain injury. But I'm going to be drawing more heavily on the update of that, which is music interventions for acquired brain injury. And then I'm also going to be touching on some qualitative research from my doctoral study. Is this for me?
Yes.
Okay, so first of all, thinking about evidence. Ray touched on this, but I want to go a little bit deeper into the evidence. When we're talking about evidence, there are three prongs, if you like, to evidence. We have not just quantitative research that he referred to, but actually meta-analyses, the systematic reviews of quantitative research studies, which I'll be going into a little bit more detail about. But we also have expert opinion of the trained clinicians who are delivering the interventions. And then most importantly, we have the client-patient preferences of what they find useful. So talking a little bit more about all of these, first of all, touching on Cochrane reviews and what these are. What Cochrane reviews do is they look at all the research that's taken place on a topic, whether it be qualitative or quantitative. They remove all the qualitative or mixed methodology research, and they focus on quantitative research. They focus on quantitative research, which fits a very rigorous set of criteria. And then the research which meets this criteria is actually pooled together so that we have large amounts of data. Rather than these small pilot studies, we manage to get larger numbers. And the importance of this is that in rehabilitation, numbers count. In essence, numbers count, and I'm going to be coming back to that point in a moment. And it's not that I am somebody who champions quantitative research by any means, but actually in some fields it can be very important to understand why the quantitative evidence holds such weight that it does. So I've already mentioned in rehabilitation, so today I'm talking about working with adults and those who have acquired brain injury of a non-degenerative nature, whether that be through trauma, anoxia, stroke, or viral infection. And I also want to say that I'm not just referring to older adults today, because as we saw from the events on Friday, actually the incidence of acquired brain injury really spreads across the whole lifespan. And with the incidence of war and terrorist attacks, we're certainly seeing it being more prevalent in a wider group of society. I'm also going to be just touching today on people with neuropalliative conditions, people living with multiple sclerosis, Huntington's disease, Parkinson's disease. So although these are degenerative, I just want to touch on some of the research there as well. So, in terms of the evidence for music with acquired brain injury, this is the published evidence as it stands from the meta-analysis, the Cochrane review. The review that we published in 2010, after surveying all the literature on, at this time we were looking at music therapy with acquired brain injury, we were able to actually only include from nearly 4,000 citations that we found. We actually were only able to include 7 studies, which gives you some idea of the rigorous criteria that Cochrane use. And again, there's a lot of debate about this, and I'm certainly critiqued from within my own profession for even engaging with the Cochrane reviews. But my attitude is, unless you engage, you can't really start to argue or critique why we should be using or not one particular methodology. So the outcomes we were interested in, or that we said at that time, were gait, arm function, communication, behavioural outcomes, and pain. Or rather, these were the outcomes that we found evidence for. Now again, Ray touched on outcomes. Should we be thinking about outcomes? You'll notice there's not well-being here. And this is one of the problems with looking at quantitative research, because we need to measure, we need to be examining measurable outcomes. And actually some of the really important outcomes, like identity, self-concept, well-being, are very difficult to measure well using standardized measures. So there's a lot of work that we, everybody in this room, we and the wider community need to be doing to develop good measures that are appropriate for the populations we're working with. So our evidence ended up being based on only 2 studies from nearly 4,000 citations. And what we found evidence for was gait. And particularly, rather than gait, we found evidence for specific methods that used rhythm. And we found that these rhythm-based methods were effective for improving gait. So here I'm touching on not just using music as a whole. We're not talking about just music listening, music playing. We're actually looking very specifically, what are the methods, the defined, operationalized methods that are useful, and what is it in these methods that seems to be useful? And the take-home message from my presentation might be, rhythm works. Okay, numbers count and rhythm works. And we found that rhythm might also be useful in arm function. Now, I want to come on to showing you some video of what these interventions look like, what it looks like working with people who have acquired brain injury, with trained clinicians who are using these types of methods. And I've got a couple of bits of video I'm going to share. The first one is about 3 minutes long. It's from a video of the work by music therapist Sarah Johnson, who you will see in here. And Sarah was instrumental in developing the methods of neurologic music therapy that some of you may have heard about. She was the clinician that really developed these. And we're also going to see the story of a gentleman called George, who had a stroke after a medical procedure. And what I want you to look at in this video is Sarah and George talk about these music methods to assist him in his physical rehabilitation. So very much again looking at physical functioning. But try and have a look at the amount of physical effort that George is using to do this work. Listen to what he says about how music helps him. And we're touching here, indirectly, we're touching on the role that music has in terms of being a motivational factor, and how music can be, how music can assist patients, people with acquired brain injury, engage in their rehabilitation. You can start the video now if you like. So when we look at that video, what we can see is that music is being used to enhance functional gains. You could see that he was practicing playing music using instruments as musical targets, while Sarah structured the music to shape his movements. These movements enabled that man to feed himself independently. So I understand that this may not be seen as music for well-being, but actually this is what matters with the patients we work with: walking, talking, and having some level of independence. I have a 90-second video. Do you think we could look at that before because we will be stopping at 11 o'clock for the silence. I'm going to just come on to one more example, and I want to thank music therapist Alex Street, who's in the audience here for this example. Thanks, Alex, who's also a doctoral candidate at Anglia Ruskin, and he's doing his research on TIMP, the method we just had a look at. And this is an example of rhythmic auditory stimulation that we looked at in a Cochrane review, that we have the best evidence for in the Cochrane review. So this is very short, and then we'll stop for silence. So this is first of all the man walking before intervention independently. You can see an uneven gait, unequal symmetry. He's needing somebody for assistance. He has to use the wall. And then this is using the rhythm-based method. We can see his symmetry, his walking's more symmetrical, he's independent. He manages to stop independently, and I think, and here he is walking even without the music, so we can see there's carryover. So this is rhythmic auditory stimulation, the rhythm-based method that we found the evidence for in the Cochrane review. So just to summarise the findings from the Cochrane review, looking at all the evidence for music as interventions for people with acquired brain injury, is that rhythm may be a primary factor in music therapy methods which facilitate functional in this population. But the disappointing outcome was that we couldn't find sufficient evidence for clinical practice to support addressing mood and emotions, communication, social skills and interactions. And yet, as clinicians, we know that these are the important areas. I've been a clinician for 25 years, and in the time that I worked as a clinician in London at the Royal Hospital, I must probably worked with around 1,000 patients directly. So I have a fair amount of expert evidence to pull on. And I also then indirectly I've worked with most probably another 200 or 300 patients as a clinical supervisor and as a researcher. And I know that there is plenty of evidence from my clinical expertise, there is plenty of evidence that these are actually the areas that we address with music-based methods. And then of course we have patient preference. I'm going to make reference to the case of Gabrielle Giffords, who many of you will have heard of, the US Senator who in the course of her work was shot in the head, and her rehabilitation had a lot of coverage internationally because of her high profile, and in particular the use of music therapy to address her communication outcomes. So we know from cases like this that there's actually, that music does work in addressing these outcomes for which we don't have strong evidence yet. And we don't have strong evidence for all those methodological reasons that Ray touched on, because the studies are not robust enough, because they don't look at the outcomes of interest, because they're not using quantitative methodologies. So I'm going to just look at a couple of important studies that have or have not made it into the most recent review, because these are so important. First of all, and I know that Frederica is also going to touch on this study a little bit, there was a randomised controlled trial that took place in Finland, which was really important with people with stroke. Nicely designed trial. Are you going to talk about the design of this trial? Oh, okay. So it was a randomised controlled trial that took 3 groups, a control group who got no intervention, a group that they listened to audio books, and then a group that listened to music. There were people who were in the acute phases after stroke, so they had measures taken at immediately in the very acute first days after stroke, then post-treatment after 3 months, and then follow-up at 6 months. And the really exciting findings from this study were that music listening during the early post-stroke stage enhances cognitive recovery and prevents negative mood. So particularly what was found was that music seemed to help with verbal memory and focused attention, more than the other 2 groups, and also that music assisted with reducing depression and feelings of confusion, more so than the control group. And what this study, this group led by Teppo Saikamo proposed was that in listening to music and audiobooks, it seems that listening assists the brain with sensory processing, which frees it up to then deal with a higher level cognitive processing of high level cognitive functions. I would also add though, as a clinician, I know we have lots of jokes about what harm can music do and just listening to a bit of music. Actually, I would also urge caution in using music, because one of my little mantras is music equals auditory information. And if we're working with people who are very profoundly brain damaged, such as those with disorders of consciousness that I have a particular interest in, it can be too much information. So I would say also, don't just put the earphones on somebody and know that listening is going to improve their cognitive functioning. We do need to think as well about the brain's capacity to actually take on this type of information. Another really important study led by Gottfried Schlaug in the US looked at intense music-based methods to address language, where they were offering this method, melodic intonation therapy, twice a day. And the findings they came out with was that after intense music-based interventions that involves the client singing, there were actually neural changes in the brain. This is a major fiber tract called the arcuate speculus. And this is before treatment and after treatment. And what they found was that after this intense treatment, this fibre tract lengthened, the number of fibres thickened and increased. So there were actually changes to the brain. And this part of the brain is important because it's a connector between different regions of the brain. And it's thought to be a connector between motor and language output. So I just want to come on to the Cochrane review that we are currently just about to submit, which we've widened the scope to look at music interventions for acquired brain injury. And this has actually increased the number of studies that we've been able to include. So this is literally hot off the press, still on my computer under that chair. Okay. And actually we may be still including a couple of studies. But it looks like we're able to include 31 studies. And we've increased the number of outcomes that we're able to look at. And I'm just going to flick on to say that gait is still the behavioural outcome that we still see the greatest evidence for, particularly gait velocity, stride length, and gait cadence. And again, using rhythm-based methods, the rhythmic auditory stimulation that we saw from Alex's clinical example. Also, we've now got evidence for upper extremity functioning, still quite a small number of studies. I would say disappointingly small number of studies looking at communication, because again, expert clinical opinion is that music therapy is very effective for addressing communication outcomes. One of the issues here is that generally there is a lack of agreed core outcomes when researching speech and language with this population. And so this is an area that's been looked at more widely within rehabilitation research. We saw some beneficial effects for mood. We're still not getting at that one well enough in the research, and no strong evidence for these outcomes. Social skills and interactions, expert opinion. This is where the core work is done with music as an intervention. Now, this is particularly disappointing looking at mood. And one of the issues here is that there is one measure that's being used, the profile of mood states, but it's being used in different versions, and so we've been not able to pool data in any way that is meaningful. So one of the messages from this is that we, again, everybody in this room, the research community, needs to get better at agreeing on the outcomes, the standardized measures that we're using to research music interventions. I think this might be a little mantra from today that we're going to hear lots about. I read it in Frederica's abstract as well. Music is a complex intervention. And this is one of the problems with researching it adequately to get the evidence that we need. You heard me say earlier that numbers count in rehabilitation. Numbers count because our patients want to know that they are improving. They want to see on outcome measures that they have improved. They need that to sustain their hope. So numbers count from that perspective. Numbers also count in terms of getting funding and managers to satisfy managers that music is a valuable intervention in rehabilitation. But music is a complex intervention and it's not always possible to measure its effects. Also, we've got this very complex population, often with comorbidities. I'm sorry, I misspelled that word, with comorbidities. Often we're looking at people who have what's considered secondary effects, such as mood disorders, depression, and also once people are discharged from rehabilitation, they may be drawing on maladaptive coping skills with and using substance abuse and alcohol abuse in terms of coping. So this then comes in as a comorbidity. And when we think about this population, we're actually now, particularly when we're thinking about the veteran population returning from war with acquired brain injury, we're actually talking about these comorbidities as being factors of survival. So the question is, do music-based interventions actually increase survival with acquired brain injury? And this is the work that we really need to focus on now. But we're talking about complex populations. So we do need people who have advanced skills trained to work with this population. And also we need to be working with protocols that can be adapted, as we saw Sarah doing in that video, using music-based. She was using a protocol, but using live music, we're able to actually adapt the medium that we're using. So all of these factors are a poor fit for the evidence base. And this is just where I'm going to finish off. I'm going to touch on some qualitative research that I've drawn from my doctoral work, which was with people with neurological illness, so degenerative illness such as it was advanced and complex multiple sclerosis. But I think this research really looked at the effects on identity of music therapy. And what we can say is that using songs actually facilitates biographical work, which is where people need to do multiple reviews of their lives. And using songs, the person is able to transport themselves from their past into the present and project into the future. Particularly important when we're working with people who maybe are struggling with finding hope for their future. Songs also can enable exploration of very difficult emotional states that can work within people's coping styles. And secondly, I'm referring here to clinical improvisation, which is a method from music therapy. What I found from my research was that playing instruments in co-improvised music provided people with a forum for exploring their new physical self, exploring new physical boundaries, what they were able to achieve, and how they were changing over time. It enabled feelings of achievement, empowerment, control, and creativity. And the therapist worked as a performance validator, the person who was actually reinforcing that person's shifting sense of self. So in this slide, I'm suggesting that maybe what we also need to be looking at with music interventions is looking at how music can assist with shifting self-concepts and aiding in identity reconstitution. So, just to summarize, music interventions, there is adequate evidence now for its use with functional games, particularly with gait, arm function and communication. But the evidence for its use as a psychotherapeutic intervention, which is where it really has a lot of power, and also even its effects on cognition with people with acquired brain injury remains elusive. So this is our future direction. Thank you.